So before going to in details of the topics, let's talk about, we know that definitely two types of the diabetes we know. There is the type 1 diabetes mellitus and that is the type 2 diabetes mellitus. Okay. Now in which cases we'll see this type of the cases since like the diabetic ketoacidosis is the first question. So we know that the diabetes type 1, this happens due to the severe deficiency of insulin. Okay. And this severe deficiency of the insulins, that is responsible for DK, or I mean the diabetic ketoacidosis. Okay. Because there will be like the insulin level will be so low. But in case type 2 diabetes mellitus, in case 8, we can also see the diabetic ketoacidosis but mild, but not much, just like this. Okay. What's the main reason behind 8? Because you know that within the pancreas, the beta cells that is responsible for productions of the insulin. In these cases, we know that in type 1 diabetes mellitus, we will see there is a production of the autoantibodies against these beta cells. Now, whenever there will be autoantibodies against these beta cells, there will be destructions of the beta cells. As a result, we will see productions of the very little amount of the insulin that will be not sufficient to do the functions. Now, whenever there will be like the deficiency of the insulins, in this time, what type of the problem we will see? Before that, let's know about in which conditions we will see this type of the problems. Okay. Now the first thing, let's suppose a person is diabetic, but he is not doing his diagnosis for a long time, but he is diabetic. If the person is not taking any types of the advice from the doctors, then we will see that there will be what? Progressing destruction of the beta cells. There will be severe amount of the destruction of the beta cells. As a result, we will see the severe deficiency of the insulin there. So, if the person is not diagnosed, the second thing we will see here, let's suppose a person is diabetic. Okay, he is having diabetes type 1, but his body needs more amount of the insulin suddenly. That means if the dramatically demand of the insulin is getting increased in our body, at that time we will see there will be this type of the problem. So if the demand of insulin increased dramatically, then you can see this type of the condition. Now in which circumstances we will see, let's just suppose the person is having a type of the infections. Infections may be regarding from the GIT infections, or maybe from the UTI, urinary tract. Okay. Or it may be for, let's suppose the person is having surgeries, or it may be for myocardial infarctions. It may be present also in the cerebral also infarction there in the brain, or it can be also in case of the trauma. In these circumstances, we can see the diabetic ketoacidosis. But the most important cause is that I didn't say you. I am writing with the red pen. That is the failure to take insulin. Failure to take insulin. What do I mean by it? Let's suppose a person is having diabetes. Okay. For any disease, he has not eaten he has not taken his food for the whole day, and he is thinking like this, that I have not taken any food for the whole day, so if I don't take the insulin, there will be no problem. But the problem will be there, but he is not educated that much from as far as the medical science is concerned. So he is thinking that if I don't take, then there will be no problem. That's why he is not taking the insulin. That's the failure to take insulin. Okay. Now in these cases, we will see there will be increase the risk for the increasing risk for the diabetic ketoacidosis. Okay. Now, whenever there is like a severe loss of the insulin, let's suppose the deficiency of insulin will be there. At that time, we will see in our body there will be productions of some counter-regulatory hormones. Counter-regulatory hormones. And these counter-regulatory hormones, they will help to maintain the situations. The counter-regulatory hormones means which hormones? These are the glucagon. The second one is, it's cortisols. Third one is epinephrine. And the fourth one is growth hormone. Actually, there is a balance in between the insulin and these counter-regulatory hormones. No fun in telling that glucagon, the pancreatic, it will be secreted by the pancreatic alpha cell. Then this cortisol from the adrenal cortex, we will see. Then this epinephrine from adrenal medulla. And this growth hormone from the anterior pituitary, you know it, right? Now, what is the main problem? Actually, there is a balance in between insulins and these counter-regulatory hormones. Let's suppose I am writing here insulin, and I write CRH stands for counter-regulatory hormones. So there is a balance in between those two things. Now, whenever there will be less amount of the insulin, the amount of the counter-regulatory hormones will be more. Okay. Now, in these cases, we will see there will be also like the ratio of insulin and glucagon that will be disturbed. As a result, these things will be activated too much, and they would like to, they will try to take back this situation into normals. As a result, they will start the process of glycogenolysis. They will also start doing the lipolysis. Okay. Now we'll talk about the pathogenesis. This is the normal introductions. Now we'll talk about the pathologies or pathogenesis. To understand the pathogenesis, what type of the organs are involved here, the peripheral tissue organs, we need to know about them. For that purpose, I'll need to draw a little bit. Just be with me. Let's suppose the general circulations in our body. Is the general circulations. Now, here we will see the peripheral organs. The organs, just in a word we can say. And let's suppose drawing is not good, that much good, but for understanding purpose I am drawing. So then we will see let's suppose the pancreas. Here is the liver. Okay. And what type of the organs are involved here? We need to know about them. For that, I will draw. Let's suppose you can also draw is the adipose tissue. Adipose tissue. Then I will want to draw muscles. Then I need to draw nephron parts. Okay. Then I will draw the central nervous systems because all the organs are involved here. And I will also draw for the GI systems. And definitely I have to draw also for the lungs because this mechanism is also present here. Anyway, now see the main problem where we were. I said there will be like what? Deficiency of the insulin. And whenever there will be deficiency of the insulin, definitely I said you that counter regulatory hormones that will be more, and they would like to do the glycogenolysis. So first they will activate the hepatocyte cells. These cells will be activated by these hormones. So let's suppose it's the hepatocyte cells, and from here they will start the process of glycogenolysis. Glycogenolysis. So let's suppose the glycogen, and they will help to break down this glycogen and to form the glucose. Okay, by the process of glycogenolysis. So the process is glycogenolysis. So I will do, I'm writing it here, glycogenolysis. The next thing they will do, they will also produce the glucose from the non-carbohydrate sources. Let's suppose the non-carbohydrate sources also there. By the process of neoglucogenesis. Neoglucogenesis. By this process they will also produce what? Glucose, that will be more. Now, what's the main problem with these two cells? Okay, we know that insulin dependent the blood transporters are here. That means what? Here also. That means in the adipose tissue and in the muscles. Is the muscles. Now, what type of the problem is here? In type 1 diabetes mellitus, we know that there is severe deficiency of the insulin, but these, blood transporters, this is blood 4, is also blood 4 here. Now these transporters can't work, they don't have any functions in the absence of the insulins. So the main functions for them, whenever some persons, anybody under normal physiological conditions, if someone is eating anything, whenever the glucose level is getting increased, normally it will go here, okay, by the transport, or by the mechanisms of the transporting of the blood 4, this glucose will be taken by these adipose tissue cells, and this glucose will be taken, that's the muscular cells. But the problem is here, whenever there is like severe deficiency of the insulin, at that conditions they can't work well, okay. So the amount of the glucose here will be also low, the amount of the glucose here will be also low. So let's talk about for the first, the muscular cells. Whenever actually the glucose is more here, okay, the person has eaten already, glucose is here more, but due to the deficiency of the insulins, this transporter can't send the glucose within the cells. As a result, these particular cells, they are thinking maybe there is a glucose, the levels of the glucose has been dropped within the circulatory systems. So within the muscles there is like presence of what? Glycogens, storage of the glycogens. Then this glycogen will be converted into glucose 6-phosphate. The muscles can't convert the glycogen into glucose directly, because the enzyme that is required for the final step from glucose 6-phosphate to glucose, that is not present within the muscles. Okay. So this again, further this glucose 6-phosphate will convert into the lactate. Okay. And this lactate can be taken by this liver, and this lactate will convert this lactic acid will be converted by these livers into the glucose, and they will come within the blood. So amount of the glucose increase, and this glucose may be utilized by this liver under physiological conditions also. That is known as the Cori's cycle. Okay. Now what's the another problem? Within the muscles there is also protein. Now this protein will also get breakdown. Why? Because there is deficiency of the glucose, because they are not taking the glucose, they are not getting the glucose within them. So they are thinking, these peripheral organ tissues are thinking, they are assuming that maybe there is like the drop of the glucose within circulatory systems, but actually the glucose is there. Because of the deficiency of the insulins, they are not getting the glucose, so they are thinking it's normal for them to think just like this. So this protein will get break down into the amino acids, and this amino acid will be taken by this liver. It will go to the liver, Again it will go to the liver, and after going here it will again produce the glucose. As a result, we will see productions of the more amount of the glucose within the blood, hyperglycemia states. Okay. Now, what type of the problem we will see in the adipose tissue? We all know that within the adipose tissue there is presence of the triglycerides. Okay. Now, whenever this triglyceride is there, whenever these adipose tissue cells are not getting the glucose at the time, they are thinking maybe there is also the deficiency of the glucose in the blood. At the time, the counter-regulatory hormones, they will stimulate a particular enzyme here that will break down. This is known as lipoprotein lipase. Okay, lipoprotein lipase. They will activate this enzyme and they will convert this triglyceride into free fatty acid and into the glycerols. They will convert into the free fatty acid into the glycerol. Now these free fatty acids, this free fatty acid will be taken by the liver. This will be taken by the liver. Now what liver will do? After coming here, these free fatty acids, some of the free fatty acids, they will, by the process of nucleogenesis, they will produce glucose. So more amount of the glucose, more hyperglycemic conditions, and some of the free fatty acids. Okay, some of the free fatty acids. Let's suppose I am drawing a hepatocyte cells. Hepatocyte cells. Okay. Now some amount of the free fatty acids that will be taken by these cells, and these free fatty acids will be taken by the mitochondria presence within it. This mitochondria, just like this. Okay. And we know in the mitochondria there is a carnitine systems. Carnitine, like 1 and 2. They will go through these things, and by the process of beta oxidations, what we will see that from the free fatty acids we will get the ketone bodies, and what type of the ketone bodies we will get, that we have to know. The ketone bodies we will get the beta hydroxy butyric acid, beta hydroxy butyric acid. Then we will get the acetate. Then we will get acetone. So what type of the ketone bodies we are getting? Let me write here also. We are getting beta hydroxy butyric acid. We are getting acetate, and we are getting also acetone. Okay. Now this beta hydroxy butyric acid is the most abundant. It's the most abundant among the three. Yet this beta hydroxy butyric acid don't have any keto groups. Don't have keto groups. But they are also ketone bodies. Now after coming within the blood, they will release more amount of the protons because they are what? Acids. So they will release more amount of the protons. Okay. Now, whenever this more amount of the protons are here coming here, so the pH that will dramatically get down, which will be low. Now to maintain these conditions in our body, we are having the bicarbonates, presence of the bicarbonate. This bicarbonate will be here, and this H plus. After that they will react with each other and they will form the carbonic acid, H2CO3. Okay. After forming this carbonic acid, we know there is the presence of the carbonic anhydrase enzyme here that will form this carbon dioxide plus water molecules. Now this carbon dioxide, okay, this can cross the blood-brain barrier, that can cross the blood-brain barrier, and they after crossing this blood-brain barrier, they will go to the inspiratory center, and they will activate these lungs, these muscles, especially the intercostal muscles, and as a form they will come out CO2. And the most important thing regarding this thing, that this CO2, whenever it will come out, in this case we will see this breathing is known as the Kussmaul's breathing. Most important thing regarding the diabetic ketoacidosis, Kussmaul's breathing. In this case, we will see the tidal volume that will increase. Actually, whenever the Kussmaul's breathing will be there, we will see the persons will take just inhale just like this. The tidal volume that will get increased. Okay. Now, yes, one more thing, then we have got it, acetone. This acetone, it will also released by the lungs. This acetone, it will also come out. And whenever this acetone will come out, this acetone is having a particular smells, the definite smell, that is the fruity, sweet fruity smell. Sweet fruity odor. Okay. By just it's one of the major signs and symptoms to understand whether the patient is having diabetic ketoacidosis or not. Okay. So whenever this H plus are too much here, our body is having the HCO3 bicarbonate, I am saying, but that much bicarbonate will not available at that time to neutralize all the H plus. So some of the H plus, they will come within the central nervous systems, and they will activate within the middle of the nausea and vomiting center. They will stimulate this nausea and vomiting center. Along with it, they can also stimulate these GI systems. As a result, we will see the vomiting. Okay, they will start the vomiting. Now, we have to talk about from the aspect of this glomerulus. Now, whenever this hyperglycemia is there, definitely let me tell you one thing, that whenever this more amount of the glucose is coming out, that will also come definitely through the glomerulus. And whenever this glucose is coming too much, the main problem is here, that the glucose will be reabsorbed by these PCT cells. We know it from the basics. But the amount of the glucose will be so much that these PCT cells can't reabsorb all the amount of the glucose molecules. So there is also there will be some amount of the glucose that will come out through the urines, and that will cause the glycosuria. The presence of the glucose that will cause what? Glycosuria, we can say glucoseuria. Glycosuria you can see. Okay. Then the other things we can see also, there will be productions of the more amount of the ketone bodies. So the ketone bodies will also be filtered by these things. So some amount of the ketone that will also come out in the form of urine. So we can also see the ketonuria. And whenever glucose is coming out, because we know that glucose is having the such chemoosmotic properties for which it can attract, it can take lots amount of the water along with it. Okay, it is having the chemoattractive properties, so it can take more amount of the water along with it. As a result, we will see the polyuria. So more amount of the water that will come out here. So we will see the polyuria. Now the problem is, whenever the more amount of the water is coming out, at the time in our body, the blood, that will be hyperosmolar, because there is the water molecules will be less, but the electrolytes will be more. As a result, our blood that will be hyperosmolar. And whenever our blood that will be hyperosmolar, okay, let's suppose whenever this blood is getting hyperosmolarity, okay, and during that it will activate this brain, hypothalamus, the thirst center. Okay, so as a result, we will see the persons will see the polydipsia. The person will feel thirsty to maintain the osmolarity, and that will be done by the thirst center that is present within the hypothalamus. Okay. Now these are some things regarding the diabetic ketoacidosis, but regarding this H plus, I want to talk one more thing, that let's suppose it's a cell and this cell is having H plus. It can just take H plus, so proton, potassium antiproton, and release K plus outside. Now whenever the cell is taking, the more amount of the H plus is getting here, so some amount of the H plus that will come here also, and that will release what? Potassium. As a result, we can see also in this patient hyperkalemia. Okay, hyperkalemia. Now regarding hyperkalemia, whenever the person is having hyperkalemia, he is having some problem regarding the cardiac problems. From the aspect of the cardiovascular systems, he can suffer from some problems. So to maintain these things, we have to do the treatments or the management of the diabetic patients. So the management of the diabetic ketoacidosis patients we will do further. So the main thing is here regarding the findings, clinical findings. You can say a little bit more, but we'll talk about all the things in the subsequent videos. Okay, thank you for watching. And if you don't understand any points regarding any concepts regarding all the videos, lectures, just let me know in the comment sections. I'll help you as much I can. And if you're new, please do subscribe my channel and support me, then I can make more videos. Okay, so just do encourage me. Thank you for watching.